everybody. I welcome all of you to the Silver Jubilee Oration of today's AOGS program. I welcome Dr. Jignesh Deliwala sir, who has recently been elected as Honorary Treasurer post in Sogok for the tenure of 2022 to 2024. And Dr. Munjal Pandya sir, our Secretary of AOGS sir, for chairing the session. Thank you.
Very good evening, my respected seniors and dear friends on behalf of AOGS. Myself and Dr. Munjal would like to invite you this Silver Jubilee Oration of AOGS, which is presented by Dr. Jaydeep sir from Mumbai. It is my proud and privilege to invite Dr. Jaydeep sir for this oration. I think in this audience, everybody knows Dr. Jaydeep Tank. He is Secretary General, Federation of Obstetrics and Gynecological Society of India for 2018 to 2021. He was project lead FOXY USAID projects 2024. He was past president Mumbai Obstetrics and Gynecological Society. He is Deputy Secretary Asia Oceanic Federation of Obstetrics and Gynecology. He was immediate past Chair International Federation of Obstetrics and Gynecology, that is FIGO, for safe abortion. He was past Chair Publication and News Letter Committee, AOFOG. He was past Chair Reproductive Endocrinology and Infertility Committee, AOFOG. And he was also past Chair of MTP Committee, FOXY. He was recently awarded the FRCOG in 2020 by the Royal College of Obstetrician and Gynecologist, and is to be conferred in this year. Right now, he is a consultant at Ashwini Maternity and Surgical Hospital, Center for Endoscopy and IVF, co-founder of Healthcare Private Limited Program Director and member of board Profert IVF. He is also visiting consultant for IVF at more than a dozen of IVF centers. He was instrumental in drafting the proposal for FIGO, which has resulted in a grant of $30 million of a 10-country project, 8 in Africa and 2 in South America, and is the technical lead of the project. He is also working on developing a project for the MOGS geared toward assisting underprivileged women in urban slums with their menstrual hygiene needs. He has contributed to the electronic membership management system and e-voting for the FOXY, developing a completely redrafted user-friendly constitution for FOXY. And because of the e-voting started in FOXY in Ahmedabad also, we had started e-voting since 2 years. And contributed and led the development of the FOXY statements on cesarean rates, hysterectomy rates, contraceptive implants, ART bill, surrogacy bill, the FOXY, WPs, and intervention in Supreme Court on PCP and DT Act. The IRA case, the oxytocin case, and others, and restructuring the FOXY cells, the minutes of the FOXY MCM and GBMs, and several other initiatives. So I welcome Dr. Jaydeep Tang sir for this Silver Jubilee oration. And before we are going to start the oration, I would like to invite Dr. Munjal to read the scroll for this oration.
Thank you. Thank you, sir. Ahmedabad Obstetrics and Gynecological Society feels honored and has pleasure to award Silver Jubilee Oration for the year 2021-22 to Dr. Jaydeep Tank. Date 19th March 2022, Saturday. Subject PCOS, a practical approach. Dr. Jignesh Deliwala, President AOGS. Dr. Munjal Pandya, Honorary Secretary AOGS. Thank you, sir.
Very good evening to everybody. First of all, let me thank all of you for taking time out to come and attend this Silver Jubilee Oration. It is indeed my pleasure, and more than pleasure, it is a very deep privilege to come to the Ahmedabad Society to deliver this very prestigious oration. I must thank the President, Jignesh Bhai, and the Secretary, Munjal, for arranging this oration and inviting me for this oration. It is a real pleasure and privilege. It also brings back a lot of memories. The last AICOG which was here, we had stayed in this hotel, and we really had a very nice time. And also, I was just passing by the campus of the Gujarat College, and my father did his inter-science from Gujarat College. And when Dr. Behram Anklesaria was there and we had done the AICOG over there, that was also a very nostalgic moment for my father, and I was very fortunate to have been a part of that. Normally when I go to, you can keep the lights on, people might sleep otherwise. That's fine, thank you. Whenever I start a presentation at any of the societies that I go to, I always try to take the name of the people whom I know in the society. And when I was going through the list of the office bearers here, Kamini Ben, Mukesh Bhai, Snehal Bhai, Neeta Ben, Sashwat, Alpesh Bhai, the past president, I realized that if I have to read out everybody's name, I'll have to read out the entire roster of the Ahmedabad Society. So you will excuse me if I don't mention everyone, but I'm delighted that Atul sir, Atul Munshi sir, MC Patel sir, Rajni Bhai, Pragnesh Bhai, Lata Ben, Sujal, you'll have all taken time out to be here. It's always such a pleasure to meet everybody. And I must thank all the managing committee members, the ex officio members, the co-opted members, and the special invitees of the society for having me here. This oration is going to be, I hope, extremely practice-oriented. I'm not going to talk about the theories which surround polycystic ovaries, not too much talk about hyperinsulinemia and the way hyperinsulinemia is formed in PCOS and all that kind of stuff. Let me try and focus instead on a very practical approach where I try and tell you what we do very practically when there is a patient who either is suspected to have PCOS or actually has PCOS is sitting in front of me in my cabin. But before I begin, let me request all of you to please support me as I stand for the presidency of FOXA. Thank you. Thank you, Rajni Bhai. Thank you. I don't know if all of you have received that slip of paper which I had requested them to give when you entered. But that slip of paper is a bit of an interesting thing. It's actually a wristband. So there's a small adhesive on one side of that paper. So if you open that adhesive, as Rajni Bhai is showing, you can wear it as a wristband. The idea is that you'll take a picture holding it like this, which Munjal and several other of you have done, and put it up on WhatsApp or Facebook to show that you're supporting me in my campaign. But there is also a QR code on this paper. And if you take out your mobile phone and scan that QR code, it will take you to my election website. I believe it's the first time a website has been set up for a FOXA election. It's called isupportjaydeeptang.com. And lastly, and very importantly for me, this paper is actually handmade and it's recyclable and it's impregnated with basil seeds. So when you go home, please don't throw this paper away. Put it in soil in your garden or put it in a planter. And if you water it every day for 10 days, you will see a basil plant growing. And if you see that plant growing, I will be very obliged if you take a picture of that plant and share it with me. It always gives me great delight to see these plants growing from what seems to be an ordinary piece of paper. I will begin my oration on PCOS first by showing you this slide. Now this is a screenshot of a Medline search that has been done, as you will see, for PCOS. Can I have the pointer, please? I think it's there. You will see that when you do a Medline search for PCOS, you will see close to 13,000 results in a Medline search. What is of importance, however, in this slide is this green graph over here which appears whenever you do a Medline search. I feel we don't pay enough attention to this graph. But this graph talks about the number of articles that are published every year on the topic that you're searching for. So for example, and I've blown up this graph here, you have a graph which starts tall and then keeps on going down. It means that the number of articles being published every year on the topic that you're searching for are constantly reducing, and therefore either all the issues which surround the topic have been sorted out, or that topic is not of interest anymore in modern literature. But if you see a graph like this, like you see for PCOS, where it starts small and then keeps on increasing, and look at the number of articles published in 2021 for PCOS, 1,459. That really is a huge number of articles for any given topic. It is rather obvious that PCOS is a very current topic. There's a lot of work being done on PCOS, and moreover, there are a lot of publications happening in the field of PCOS. I've always thought that the polycystic ovarian syndrome is extremely controversial. There have been controversies about everything in PCOS, starting from naming the syndrome, to the diagnosis of the syndrome, to the treatment of the syndrome. And I've always felt that PCOS should not mean polycystic ovarian syndrome, it should rather mean polycontroversial ovarian syndrome, because there simply seems to be no end to the number of controversies which surround it. So we'll start by talking about a guideline to the guidelines on PCOS. Sometimes it becomes a little difficult to remember what guideline says what with the Rotterdams and the Amsterdams and the Thessaloniki. So this is how the guidelines of PCOS started. It started with a guideline at the NIH, that is in the US, and look at what I have written in bold over there. This was based on a consensus questionnaire of the attendees rather than clinical research data. And this, in my mind at least, has led to further controversies in the field of PCOS, because rather than relying on evidence, they relied on consensus. This was a very large guideline trying to encompass everything in PCOS. So we started with the NIH guideline. This was then followed by the Rotterdam criteria, and the Rotterdam criteria essentially had to do with the diagnosis. Again, see how this guideline was formed. This guideline was formed closed session consensus. They of course took into cognizance the evidence, but at the end they did not base their conclusions on evidence, they based their conclusions on consensus. So you had the Rotterdam, then you had the Thessaloniki, which talked about infertility treatment, and then you had the Amsterdam one, which talked about women's health aspect of PCOS. So there were 4 broad guidelines. There was the NIH. NIH was then superseded by Rotterdam, Thessaloniki, and Amsterdam. What was common to all of them was that although they took evidence into consideration, they all seemed to be consensus-based guidelines, which was always a problem. So around 3 to 4 years back, there was an ASHRAE and ASRM partnership. They had a meeting in Australia, and they invited 70 world leaders in PCOS, international consumer groups, and what they did was prepared a guideline according to what is known as the Agree To and the Grade framework. And when they looked at all the evidences, they finally came out with these recommendations, which have been published as a series of articles, which you can see over here. So what I've done is that amongst the talking points of the presentation, starting from ethnicity to oral ovulation induction, right down to the need for long-term treatment, I will first discuss each aspect, and then I'll round it up with what that gold standard guideline now says. So Rotterdam, Amsterdam, Thessaloniki, etc., to a certain extent are either validated or not validated depending on this guideline. So let's start with ethnicity first. And these are some articles which we had reviewed, particularly that one by Vijay Ratne, who had collaborated with Balin. It was a Sri Lankan UK collaboration. I was invited to Hong Kong as part of a small group which discussed whether PCOS in Asians is different from PCOS in Caucasian women. And the consensus of literature at that time seemed to be that yes, in Asians, PCOS seems to occur at an earlier age, is more prevalent than Western counterpart. When the metabolic syndrome does occur, the metabolic syndrome is more severe in Asian women, and typically Asian women present for treatment much earlier. Now, whether this is because of cultural issues in terms of mothers getting worried for irregular periods, etc., or whether it is because the problem is more severe is up to question. The implications of all this essentially are that for long-term issues, particularly in those who are found to be syndromic, treatment should be more aggressive and instituted early. However, treatment of short-term issues is as of now unclear. This has another very much broader implication. There is excellent data coming out from the UK. I know of at least 3 studies which compare in the UK outcomes in IVF in Caucasian population vis-a-vis Southeast Asian population. And there is good evidence to show that Southeast Asian women do a little not as well as Caucasian women in IVF outcomes. Now, of course, this cannot be used as an excuse to give poor IVF results in our population, but I think it is something worth keeping in mind. When you go to the diagnostic criteria, it is now very clear that the Rotterdam consensus is now firmly grounded in the best evidence. When the NIH came out with guidelines, they looked at these 2 factors for the diagnosis of PCOS. When the Rotterdam came out, they added this ultrasound diagnosis of polycystic ovaries, and they also said you need to exclude other etiologies of hyperinsulinemia and hyperandrogenemia before you can attribute that to PCOS. But within that wonderful guideline which I talked about are several nuances which are sometimes missed. And this, I think, is a very, very important nuance. I'm sure all of you in clinical practice come across this mother and daughter and sometimes the father who come to you at the age of 14 or 15 very worried that my daughter has been diagnosed with PCOS by the sonologist. They have gone to the sonologist for something else, and the sonologist says you have polycystic ovary, go to your gynecologist. So they come to you. But the fact is that ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years. That means less than 8 years after menarche. Now, this is an extremely crucial point which has somehow disappeared in our discussion. So if a girl has had a menarche at say 11 years of age, the diagnosis of PCOS on ultrasound should be completely disregarded for the next 8 years. And this is what the latest evidence says. So I think at least 60% of those who present to you saying that they have adolescent PCOS, in fact, will be disqualified immediately because of this nuance. If you are wanting to make a diagnosis of PCOS after a gynecological age of around 8 years, a transvaginal approach is preferred, and look at the follicle number that is required for a diagnosis. You need a follicle number per ovary of more than 20 and or an ovarian volume of more than or equal to 10 ml of either ovary, ensuring no corpora lutea, cyst or dominant follicles are present. Now just think about the last 10 patients you saw with an ultrasound report which said PCOS. I can bet that out of those 10, not even 1 or 2 will fit into this criteria. And that is why I think we need to start talking more and more to our radiology colleagues that please don't overdiagnose PCOS. It leads to a lot of anxiety, and I typically spend a lot more time counseling a patient that they don't have PCOS rather than informing a patient that they have PCOS. So this is something which can quite easily be avoided. It further goes on to say, when should you tell a girl that she has irregular menstruation? Irregular menstrual cycles are normal in the first year post-menarche as part of pubertal transition. 1 to less than 3 years post-menarche, less than 21 or more than 45 are the limits of saying that this period is irregular and so on. So when you tell a patient or ask a patient, do you have irregular periods? Don't only ask them whether they have irregular periods, ask them every how many days they get their period. A thing I have found very useful in clinical practice is to ask them, do you have irregular periods, that is less than 21 or more than 45 days? And the second point is, do you have spontaneous periods or not? I think if they have spontaneous periods, you will find that most of the time, the severity of the problem is going to be very low. So in terms of history taking, particularly for adolescents, these 2 points are very important. When you make a diagnosis of hyperandrogenism, we typically send testosterone. And now everybody has a phone with an internet connection, and when they look up, why is the doctor doing testosterone for me? The first thing that comes up is it's the male hormone for virility. And remember, this has a tremendous psychological impact on the patient. So don't make this diagnosis lightly. Remember that there is a potential negative psychosocial impact. Standardized visual scales are preferred, but to be perfectly honest, most of us in the clinic will not probably have access to these, we won't use it. So clinically, what I find useful to do is look at the type of hair. If a patient has got soft, downy hair, and even if that is excessive, usually that is not hyperandrogenism. Secondly, if the patient, and this is a bit of a clinical trick, when I see these adolescent girls who are worried, I tell them, turn around and let me see the nape of your neck. And they never think that anything in gynecology has something to do with the nape of their neck. And when I tell them that I don't think you have hyperandrogenism because you don't have acanthosis nigricans, they are very impressed with me. Because they think, "Arey, apan joyu." So that is another thing which you should keep in mind. Only terminal hair need to be considered in pathological hirsutism, with terminal hairs clinically growing more than 5 millimeters in length if treated. You just run your finger over the hair. If it is a coarse hair, like you would in a beard, then that is usually hyperandrogenism. If it is a soft hair or a vellus hair, that is not hyperandrogenism. If, however, you are not sure and you want to do biochemical tests, what you should be looking at is free testosterone, the free androgen index, or the calculated bioavailable testosterone. So the test that you do in a patient when you are suspecting that she may have a syndrome are these three: androstenedione and dehydroepisterone, DHEAS, dehydroepiandrosterone sulfate, could be considered if the total or free testosterone are not elevated and you still think that she is hyperandrogenic. And remember that you should ideally not start treatment for hyperandrogenism on the basis of a clinical diagnosis alone. It's always a good idea to have biochemical corroboration. I'm not talking about infertility now, I'm talking about adolescents or women who seek regular cycles, or those who have either hyperinsulinemia or hyperandrogenemia. For hyperinsulinemia, the treatment is obviously metformin or other anti-insulin agents. For the other things, COCs are actually an extremely useful form of treatment. It's always better to use the COC that has got the lowest strength of estrogen, because most of the side effects of oral contraceptive pills are actually estrogen dependent. You can, if you would like, particularly in cases of hyperandrogenism, select a OC pill which has got cyproterone in it to make sure that it addresses the issue. Now I'll move on to the rest of the presentation, the bulk of which actually focuses on PCOS and infertility. And we'll start by talking about oral ovulation induction. So I said I'll tell you clinically what I would do if a patient is sitting in front of me. I've told you about what I would do clinically. I've told you about the test that I would prescribe. And the first thing that I would do if a patient I suspect has PCOS and comes to me for infertility is distinguish whether this is a patient who has the metabolic syndrome or does not have the metabolic syndrome. I can do this either clinically or I can do it by biochemical testing, but this is the first thing that you should do. You need to triage patients, syndromic, non-syndromic. Don't start treating the infertility patients who are syndromic. Treat the syndrome first, to whatever extent you can possibly treat. That will ensure that your treatment goes easy. It also ensures that your pregnancy loss rate is going to be considerably lower than otherwise. On the other hand, if you have a patient who's non-syndromic, and remember, PCOS is a heterogeneous spectrum of disorders. It's not a single homogeneous point in time or point of disease. Then, of course, you start treating them. When you talk about letrozole, you cannot help but escape from the controversy which one paper had caused about congenital anomalies and letrozole. So before I begin talking about it, let me dispel that myth. There is more and enough evidence to support the fact that letrozole in fact does not cause congenital anomalies. The basic difference between the way letrozole and clomiphene citrate acts is that letrozole acts in the ovary. It is the hormone aromatase which is responsible for the final conversion to estrogen. This is inhibited by letrozole, which is an aromatase inhibitor, because of which estrogen levels fall. When estrogen levels fall, the pituitary thinks that E2 levels are low, and so it produces more FSH. Because it produces more FSH, you get a better follicular recruitment and a follicular growth. The essential difference between clomiphene and letrozole is that clomiphene acts throughout the system. It depresses estrogen receptors throughout the system, and it negates the feedback mechanism of a low estradiol, and by doing so has more prone to having multifollicular response compared to letrozole, which, because it acts only in the ovary, produces more of a monofollicular response. So if you look at all the recent data, including the ASRM data, the Endocrine Society data, and even the WHO guidelines, it now seems to be very clear that amongst our oral ovulation induction agents, we now have a very nice stratification. The current recommendation seems to be that whenever you are expecting a hyper response and you want a monofollicular response, start with letrozole. Mind you, start with letrozole. Letrozole and clomiphene are not competitors. I am standing for an election, but they are not standing for an election. They are complementary to each other. So in patients of PCOS, high antral follicle counts, high AMH, for oral ovulation induction, start with letrozole. However, if the recommended cycles of letrozole do not work, by all means use clomiphene citrate. Similarly, in patients who are expected to be normoresponders or low responders, start with clomiphene, and if clomiphene does not work, move on to letrozole. Now I know that there is a lot of data, and some companies actually push it also, that you can use much higher doses of letrozole, up to 5 milligrams a day or even 7.5 milligrams a day, sometimes for a prolonged period. But I'm sure you will all recall that there was a time when letrozole was banned for this particular clinical indication. And that is something which most people, again the nuance which most people don't realize, that letrozole was not banned. It was banned for the clinical indication of ovulation induction. When the drug controller allowed letrozole, it allowed with certain conditions, and that is, we are supposed to use letrozole, and these are recommendations of the drug controller. 2.5 milligram once daily for 5 days, from day 3 to day 7 of the menstrual cycle, for 3 consecutive cycles. I'm good, thank you. For 3 consecutive cycles or till occurrence of pregnancy. More than 3 courses of therapy are not recommended, and neither is giving letrozole anything more than 2.5 milligram per day for 5 days. So although there is evidence to show that higher doses or a prolonged number of days for letrozole are feasible and give results, we are in India, and these are the Indian drug controllers' recommendations which we have to follow. There is a whole lot of supplements, etc., that have been suggested, and sometimes when it comes to PCOS, I think we are like Getafix, who goes into the forest and gets some magic potions and then brings them together so tiny Asterix can whip all the Roman armies. But the fact is that there are hardly any supplements which have been shown to be really very effective in lieu of oral ovulation induction agents. Even metformin, which at one point was being given out like candy. When I used to see patients, I used to see almost 80% of patients who were coming to me from another place on metformin, irrespective of whether they had PCOS or not. So let's get this very clear. Metformin is to be used when you have a PCOS patient with a syndrome. It is not to be used empirically when there is no metabolic syndrome in that PCOS patient. Just about the only, I think, supplement which has been shown to be remotely useful seems to be myoinositol. There is some good data to suggest that pregnancy rates in non-IVF and IVF cycles improve quite well when you use myoinositol. We'll move on now to ovarian stimulation with gonadotropins in IUI cycles. For me to first say this, and I know I'm sticking my neck out a little, I'm sure there are some people in the audience who will disagree with me, but I'm going to say it anyway. Doing an IUI with oral ovulation induction agents, clomiphene and letrozole, is of no value whatsoever compared to using oral ovulation induction with planned relations. There is more and enough data to show. So for example, if there were a study where you had one arm clomiphene and planned relations, another arm letrozole and planned relations, a third arm clomiphene IUI, letrozole IUI, gonadotropin alone, or gonadotropin and IUI. Your best results very clearly would be when you use gonadotropins along with IUI. At our clinic, we do not use IUI when we use oral ovulation induction, unless and until there is a mechanical reason to do so. For example, there is ejaculatory dysfunction, or there has been some surgery on the cervix where the cervical rheology has changed. Those are the only places where we use oral ovulation induction with IUI. Otherwise, if a patient goes for an IUI, it is invariably with gonadotropins. When you use gonadotropins with IUI, it is a good idea to use only gonadotropins. Not such a good idea to mix oral ovulation induction agents and gonadotropins. I'll be talking about that a little later. And the downregulation of patients for IUI with gonadotropins is simply not useful. Don't do it. There has always been a thought that if you're dealing with PCOS, let's start with very low dose gonadotropins. I've had people telling me I start with 25 units or 37.5 units, I give it for 5 days, and then after 5 days I increase it to 75, and then I take it up to 110 and so on and so forth. But the fact is there is no evidence to support that that gives you higher pregnancy rates or a lower incidence of hyperstimulation. So there is really no point in using low dose gonadotropin. Start with whatever you normally start. If the patient seems to get hyperstimulated, simply cancel the cycle and next time start with a lower dose. That is a much better, more cost efficient approach. As I said, it's not recommended to use letrozole or CC along with gonadotropins for IUI. And surprisingly enough, the only reason you want to add oral ovulation induction agents to gonadotropins is for the cost. But if you look at the success rates of IUI cycles with gonadotropins vis-a-vis oral ovulation induction agents, it is actually quite surprising to note that your IUI with gonadotropin cycles turn out to be more cost effective compared to when you combine oral ovulation induction agents and gonadotropins. Because when you combine, say, letrozole and gonadotropins for an IUI cycle, how much injection of gonadotropin do you save? You at most save 3 ampules. The first 3 days when you give letrozole alone. You don't save anything more than that, and you compromise the pregnancy rate. So, quoting from the ASRM recommendations, the recommended starting dose is 37.5 to 50 according to them, but clinically I usually start with 75. You can give up to 14 days of stimulation in these patients. However, I find that if you start with an adequate starting dose, for me, in an IVF or an IUI cycle, it's the starting dose which really is the most important deciding factor of how well my stimulation will go. you will find that you will probably achieve ovulation by around day 10. Of course, you need to monitor the cycle carefully, but does that mean you need to keep on doing E2s and progesterone and LH? Absolutely not. The only monitoring that we do and have done since around 20 years now is ultrasound monitoring. Even in IVF cycles, I'm very fond of saying that the first blood test I do is beta HCG, 14 days after embryo transfer. I don't do day 2 E2, day 2 FSH, LH, day 9 or day 10 progesterone, nothing. I've never really found it to be useful. So use ultrasound, and most importantly, focus on your cycle cancellation criteria. Now, whether you want to cancel the cycle, if there are 5 follicles, 6 follicles, 4 or 3, probably depends on your comfort level. Our personal cutoff is anything more than 4 and more, we cancel an IUI cycle. And we cancel it not because we are worried about hyperstimulation, we cancel it because we are worried about multiple pregnancy. And that is again a very important nuance which has now come in. I'll move on to the next part of the presentation, which is ovarian drilling. Something which I believe at one point was overused and now is underused. It somehow has fallen into quite a disrepute. And I'm happy to share these papers. In fact, this was Foxy's first ever guideline on assisted reproduction. And I had written it along with Dr. Mehru Ansotia way back in 1998 when guidelines were not, in fashion in Foxy. So this is available on the journal. If you search for it, you'll be able to read it. And in that we had spoken of ovarian drilling. And this is a paper which is very special for me because it's one of the few papers I co-authored with my father. And this was on polycystic ovarian drilling. Again, that was way back in 1995. What the guidelines seem to say is that there is no need to overuse ovarian drilling, but ovarian drilling still has a small place. The fact of the matter is that even now, we aren't really sure of how exactly ovarian drilling works, how long it works, and what is the best way to do it. Consensus seems to suggest that it should be used in clomiphene resistant and ovulatory PCOS. And this is very important because you have to distinguish between clomiphene resistance and clomiphene failures. Clomiphene resistance is when you have given the maximum possible dose of clomiphene and the patient has not ovulated. Clomiphene failure is when the clomiphene has been given, she has ovulated but failed to get pregnant. In cases where she has ovulated, don't consider drilling. It won't be of any help. But in cases where she has a high AMH and has not ovulated with clomiphene, drilling will have a small place, particularly in patients who are either unwilling or unable to undergo gonadotropin stimulation. How should you do the drilling? At the most 4 punctures in one ovary. We normally do 2 or 3. Just to give you an example, at one point in time, I used to see almost every patient who came to me for infertility from outside having drilled ovaries. And sometimes I used to see the pictures and the ovaries look more like golf balls because of the number of punctures that were put on the ovary. That's not something which we should do. Ovarian atresia or atrophy is something which is of a real worry. When you do a drilling, and you should ideally be doing a drilling with a decent caseload somewhere around 2 or 3 times in the entire year, if at all, you should do it away from the hilum of the ovary and at the most make 3 or 4 punctures in the ovary, preferably with a unipolar cautery, not very deep. So ovarian drilling, even in this day and age, does have a small role. The important word here is small. I'm moving on now to preventing OHSS with antagonist cycles and scheduling treatment cycles, and I've combined these two. We know for a fact that when we talk about IVF, there are 2 big complications. One big complication is ovarian hyperstimulation. The other big complication is multiple pregnancy. The answer to prevent multiple pregnancy is self-evident. Transfer fewer embryos, you'll have fewer multiple pregnancies. But ovarian hyperstimulation was always a problem. GnRH antagonists came into clinical use perhaps somewhere between the 2000 to 2005 period. And when they came, everybody knew that they had several advantages over the agonist protocol, starting from a shorter cycle, fewer injections, lower dose. But for me, what made a lot of difference was the ability in an antagonist cycle to use the agonist as a trigger for the final follicular maturation. This one indication convinced me in around 2011, 2012 to completely shift from agonist cycles to antagonist cycles. So the last time I have done an agonist cycle in my practice and in the other maybe 16, 17 IVF centers that we go to was around 2011, 2012. And this is the reason why. In fact, this paper, I believe, is responsible for one of the most important changes in my practice. If you really ask me, given the fact that ovarian hyperstimulation is the life-threatening complication of IVF, I would say that this paper and the ability to use an agonist trigger in an antagonist cycle to prevent hyperstimulation is perhaps the biggest advance in IVF after ICSI. It has completely changed the way we practice, and the safety margin that it adds to IVF is really quite enormous. Look at this data. This is from Humaydan's paper. It was actually a consensus statement which talked about the use of agonist as a trigger. And look at the patients who had hyperstimulation in the agonist triggering arm, 0%. By this simple change in the protocol, he eliminated, or the group eliminated, the single biggest life-threatening complication of IVF. Funnily enough, another paper also in 2011 from my teacher, Professor Paul Devroy from Brussels, talked about an OHSS-free clinic by segmentation of IVF. And I think these two papers together sort of convinced me that yes, we have to completely switch to antagonist. But when we were pondering this switch, because we had already done 10 years of practice and the long agonist protocol at that time was the gold standard, it led me to paraphrase from Shakespeare to agonize or antagonize. Why is it at all a question? And these were the issues. Are pregnancy rates the same? When antagonists came, remember the early trials were dose-finding trials. And because they were dose-finding trials, they didn't know that a fixed day 6 start of antagonists right up to the day of giving the HCG would give the best outcomes. But once we came to know that, we found that the pregnancy rates were the same. It is certainly cost effective because gonadotropin use goes down and the number of injection days go down. Is it better for poor responders? Logically, it should be, because you are starting in a non-downregulated cycle. But evidence is actually split both ways. And is it safer? That is undeniably so, as I've already shown you in Humaydan's paper. The problem, according to me, was programming of cycles. And in India, programming of cycles will always be required. If you look at this NARI data, and this is old data from 2013, you'll see that from 134 IVF centers which were registered at that time, the overwhelming majority, 86 plus 22, did less than 100 cycles a year, which meant that if they did not do batch IVF, they would not be economically viable. And to do batch IVF, you have to schedule cycles. This was our calendar. This is in 2017. And this calendar shows you that we are doing IVF somewhere or another in the country on almost every working day, and sometimes, a lot of times actually on non-working days also. And these kind of work would not have been possible if we didn't do batch IVF. So the big question at that time was, how should we schedule antagonist cycles? And I believe that this was a major reason why antagonists had a slow uptake, particularly in our country, where the large majority of IVF centers do batch IVF. So these were all the ways: OCs, E2, antagonist, and delaying HCG. And I'll very quickly take you through this to bring you to what we now do in our current practice. We actually started using OC pills for programming cycles in 2005. And when we started doing that, what I did was refer to the very early data on OC pills for contraception. So how do we use OC pills for contraception? We tell the patient, if you miss one pill, that's fine, just take the next pill on the next day, take the other pill at night, and continue. If they miss 2 pills, we tell them take 2 pills, take the pill which was due at night, and that's fine. But if you miss more than 2, then we tell them you can take pills on the 3rd or the 4th day for cycle control, but for contraception, use something less. Why do we do that? Because after around 3 days of not receiving an OC pill, the effect of the OC pill starts fading away, which means you need to wait for a certain period of time between the last OC pill and starting stimulation to make sure that the effect of the OC pill is mitigated. But if you look at the early data on OC pill programming, and a lot of these papers actually are reflected in a meta-analysis which I'm going to show you next, you'll find that the concern was not so much about pregnancy rates, but rather about one, excess use of gonadotropins, and two, a pregnancy loss rate. We therefore were not that worried about pregnancy rates, but this meta-analysis came out in 2010. As I told you, I changed my practice in 2011 after those Humaydan and this one's Professor Paul Devroy's paper. But when I read this meta-analysis in 2010, and in fact this is kind of my journey on how I program my cycles, I was very disappointed. Because George Grisinger is one of the eminent personalities in IVF, publishes a lot, and in his meta-analysis, he quite unequivocally said that if you use OC pills, your pregnancy rates are going to be lower whenever you use them for programming. But other data kept on coming out. Now, this study was not powered to look at clinical pregnancy rates, but it quite clearly showed that for all the other parameters, the use of OC pills did not compromise your IVF cycle. And then this study came out from Garcia Velasco. Very interesting study, and perhaps the first study, which compared what was the gold standard at that time, that is the long agonist protocol, versus OC pill pre-treated antagonist protocol. It's probably one of the first studies of that kind, and it showed that there is no difference in outcome. They went a step further and compared cycles which were programmed with estradiol valerate versus cycles which were programmed with OC pills. So both antagonist cycles. Previous study was long agonist versus OC pill pre-treated antagonist, no difference. This study was pre-treatment with estradiol valerate for antagonist cycles and OC pill treated antagonist cycle, again no difference. So why were these data so much different from Grisinger's meta-analysis? And part of the reason why I like giving this talk is because it talks about the nuances of literature. When Garcia Velasco and again my good friend Human, who I knew in Brussels, went back to the meta-analysis of Grisinger, this is what they found. They found that the 6 studies which Grisinger included had both normo and poor responders, which was a massive bias. Because when you have poor responders as a cohort, your pregnancy rates are obviously going to suffer. One half of the studies included 30 patients or less, statistical significance because of sample size, different types of OCs, different duration of administration, but most importantly, none of them had a pill-free interval of more than 5 days, and in fact, most of them did not wait for the patient's period to come before they started stimulation. So currently, where are we at? The current understanding seems to suggest that if you use OC pills for a minimum period of 15 days and wait for a 7-day pill-free interval before you start stimulation, your results will not really get compromised. There is also luteal estradiol which can be used, which has been studied quite extensively, and again another study from Brussels which says that E2 pretreatment does not compromise outcomes. You can pretreat with antagonists. Cost efficiency is a problem here, so if we have to program for 2-3 days, we use antagonists, we don't use it for more than that. And these next 2 studies really talk about the nuance that is available in the literature on this. So if you look at this study from Kolybianakis, and it says that if you coast for 2 days before giving HCG, coast means you give antagonist, but you don't use the gonadotropin. Your pregnancy rate will suffer quite considerably. But if you coast only for 1 day, in the study by Tremelin, it shows that it won't make any difference. So if you want to coast for at most a day, not for 2 days. So this was the classic antagonist protocol where you waited for menstruation, on day 2 or 3 started stimulation, fix day 6 start of antagonist and give it daily till the day of HCG and then do the pickup. And this is what we use. OC pills, minimum 15 days, 7-day pill-free interval, make sure she gets her period and then start stimulation. Day 6, antagonist fixed start, and either you can use estradiol valerate or you can use antagonist. In fact, I think Dr. Manish Banker has just published a paper on the use of estradiol hemihydrate in oocyte donors. I remember talking to Manish Bhai about that. So in fact, we have been able to successfully program our cycles, and this is the kind of Excel sheet which we develop for all our centers. We in fact make our IVF calendar 1 year in advance. So in December of 2021, all our centers know when they are doing pickups right up to December 2022. And they can make Excel sheets like this for the entire year, so that they don't have to worry about when to call patients. But of course, the proof of the pudding is in pregnancy rates. And if you look at pregnancy rates from ISAR, you look at pregnancy rates from ESHRE, you look at them from HFEA, and you look at them from the ASRM database, you will see that the average pregnancy rates which you should obtain in unselected patients. There will always be a small subgroup of patients where you'll get higher pregnancy rates, but if you get somewhere between 35 and 45%, you're doing quite all right. And this is our experience using the same protocol which I have described, 2,950 and 3,500 embryo transfers in these years. Our pregnancy rates for self-antagonist protocol, not much different from recipient cycles, but what is most important to me is, in all these years since we shifted to the antagonist protocol, we've not had a single OHSS needing admission and ascitic tapping when we follow this protocol, and that was what I was talking about, the safety margin. Lastly, let me end with a few words about lifestyle and emotional well-being. The diagnosis of PCOS, I feel, is sometimes a diagnosis which is given too easily. And remember that the patient will carry that diagnosis with her for the rest of her life. Particularly those instances where the mother and daughter come to you at 16 years of age with a report, ultrasound report, which we now know is not to be regarded at all, and diagnosis of PCOS. When she gets pregnant at 26 years of age, the first thing that she'll come and tell you is, "Mane kidhalu mane PCOD hatu, but mane pregnancy rahi gayi." You know, so this diagnosis is not a diagnosis which should be given lightly. There should be a clear distinction between multicystic ovaries and polycystic ovaries, between syndromic patients and non-syndromic patients, because the long-term approach to lifestyle depends quite clearly on whether the patient has a metabolic syndrome or not. If she has a metabolic syndrome, then the approach to her counseling, the approach to her treatment, and her symptomatology is quite different, which will certainly have an effect on the quality of her life. Let me end with this picture. I'm very fond of this picture. This is a baby born to a lesbian couple in the UK. As you can see here, it took 4 years, 7 attempts, 3 miscarriages, and 1,616 injections. What the mothers did was that after the baby was born, they wrapped the baby in the bride blanket, and they had saved all the 1,616 injections, put them in the shape of a heart surrounding the baby, and then uploaded this picture on Facebook. As you can see, it went quite viral. And the reason I really like this picture is that it's very touching to me. It speaks to me about the efforts which infertility patients take when they come to you for treatment, and it therefore behoves that we do our best for all patients, PCOS or non-PCOS. Let me end again by reiterating my request to all of you to please support me. The election starts on Monday at around 10 o'clock. Just a few practical points, because the first 2 elections in Foxy conducted by e-voting were conducted by me. And most of the times I used to get questions saying that I have not got the link yet. The reason you don't get a link very immediately at 10 o'clock sharp when the election starts is that because there are approximately 28,000 SMSs to send out. And the server takes a little time to send out all the SMSs. So everybody should receive a link, and this time it's going to be an individualized link, just like the IAG elections. You also had the same thing. So please be patient, wait till around 12. If you haven't received a link till around 12 o'clock, go to election.foxy.org, another website which I had made for Foxy. You will see there is a place over there where you can write your complaint and send it by email. And then you will receive a call back from the person who's, from the company who's doing the elections. It's really, really very, very important to vote. Extremely important to vote. But I would not hesitate to say in this particular circumstance that it's equally important to vote for me. Thank you very much.
Thank you so much, sir, for the wonderful insight. We would like to request delegates to stay behind with regards to the lucky draw that we are going to have after memento. Thank you. I would like to invite Dr. Jignesh Deliwala, sir, President AOGS, to present memento to Dr. Jaydeep Tang, sir.
Ahmedabad Obstetrics and Gynecological Society feels honored and has pleasure to award Silver Jubilee Oration for the year 21-22 to Dr. Jaydeep Tang. 19th March 2022, Saturday. Subject is PCOS, a practical approach. Thank you. Thank you, sir. Kindly accept the memento and
Session. As always, Sun Pharma and all the three divisions are with us with regards to any of the academic activities that we have. Even the PG symposium that we have been doing for last 4 years, whenever offline, all the three divisions are always there with us. Thank you so much for that. So I would request Jaydeep sir to select the 5 of the lucky winners from the podium. Okay, Sarnu kadaચ નાખ્યું. Number 56. Can we have the register, please? Yeah. Dr. Bharat
Parikh. સાહેબ આવી જાઓ. સાહેબ આગળ જ ઊભા છે ઇનામ લેવા.
Number 39. Dr. Azadi Patel. Number 44.
Dr. Pratibha Vora.
થોડું સર બાઉલ એ કરું
Number 2.
Jaydeep.
Jaydeep Tang, sir. Well, actually, number 1 was myself.
જાણી જોઈને નહીં કર્યો હા તમે.
Thank you, sir.
હજી એક છે. પાછું નંબર 2 આવશે તો then there is a problem. Number 10. તમે ઉલટું વાંચ્યું તો મને 1 લાગ્યું.
Yes.
Dr. Nandini, madam, yes. So thank you so much all the members for making it a huge success by coming in a huge number, and this particular recording will be available on YouTube channel as well. Will be shared soon once we get the edited version. Thank you so much. Thank you.
MC Patel sir.
Sir,
We would like to request all the delegates to have the voting done as early as they get the link with the same.